Psalm 34, verse 17. The righteous cry out, and the Lord hears them. He delivers them from all their troubles. In this final part of our lecture on the motor systems, we're going to talk about the lateral activation system. In our discussion of the lateral descending motor tracts, we have several abbreviations, aka, also known as LCST, lateral corticospinal tract, UE, upper extremity, LE, lower extremity, LMN, lower motor neuron, UMN, upper motor neuron, MN, motor neuron, L, lumbar. Additional abbreviations include DTR, deep tendon reflex, and SCI, spinal cord injury. The lateral descending pathways are important in fine motor control. They provide control of all muscles, but are particularly important in the distal limbs. And they are important in overall movement of the limbs. They are less involved with the trunk. There are 3 tracts in the lateral activation system. They are the rubrospinal tract, the lateral reticulospinal tract, also known as the dorsal or medullary reticulospinal tract, and the lateral corticospinal tract. The lateral corticospinal tract is going to be traveling with the anterior corticospinal tract in the cerebrum and the brainstem, where they form the medullary pyramids. Thus, this tract is also known as a pyramidal tract. You will need to know the location of the lateral corticospinal tract in the spinal cord and the location of the corticospinal tract that it is a part of in the cerebrum and brainstem. You will not need to know the specific location of the rubrospinal tract or the lateral reticulospinal tract in the spinal cord, but recognize that all of the tracts of the lateral activation system are located very close together in the spinal cord. Fractionation is the ability to activate individual muscles independently of other muscles. This allows us to move joints separately from each other and is what gives us our ability to have fine motor control, particularly in the hand. It's a very important function of the lateral corticospinal tract, allowing for our fine dexterity. When there is damage to the lateral corticospinal tract or to the corticospinal tract in the brain or brainstem, we lose the ability for fractionation, although we may still have the ability to move the limb in a more gross fashion through our other descending motor tracts. The rubrospinal tract originates in the red nucleus of the midbrain. Rubro means red. The axons cross immediately in the midbrain to the contralateral side, and then descend in the rubrospinal tract to the spinal cord. The rubrospinal tract may enable initiation of distal limb movement, and in this way can be a source of return of function following a cerebral injury when the corticospinal tract is damaged. But it does not allow for fractionation, so the individual will tend to have more of a total hand kind of activation. So they cannot move the fingers separately from each other, but they all will flex together and extend together. The rubrospinal tract receives input from the cerebral cortex to help modulate its activity. The lateral or medullary reticulospinal tract is situated immediately next to the lateral corticospinal tract and the spinal cord. It receives input from many different areas of the brain and is likely a major contributor to functional recovery following stroke. Like the rubrospinal tract, it does not allow for fractionation of the digits. The lateral reticulospinal tract is very important in the inhibition of phasic and tonic stretch reflexes. Current evidence indicates that it is likely to be the lateral reticulospinal tract and not the lateral corticospinal tract that is involved in the development of hyperreflexia and its resultant spasticity. At the bottom of this slide, I have a link to an image showing an individual having their DTR assessed and showing hyperreflexia of that deep tendon reflex. The lateral corticospinal tract starts in the cerebral cortex and terminates in the spinal cord. As mentioned with the medial descending tracts, the lateral corticospinal tract and the anterior corticospinal tract travel together as the corticospinal tract through the cerebrum and the brainstem, and form the pyramids on the anterior surface of the medulla. The function of the lateral corticospinal tract is voluntary movement. It is probably our most important tract when it comes to voluntary movement, and it is the only tract that allows for fractionation. An injury to this tract is associated with a positive Babinski sign. The lateral corticospinal tract is particularly important for the control of hand muscles. It is not necessary for walking, which is rather interesting. Our medial reticulospinal tract and central pattern generators that are likely initiated by that medial reticulospinal tract are more important for creating the gait pattern at our trunk, hips, and knees. However, the lateral corticospinal tract is required for the control of foot and ankle muscles during gait. Somas of the neurons that will be traveling in the lateral corticospinal tract are spread out in the cerebrum from an area in front of our primary motor cortex to some of the sensory areas in the parietal lobe. However, the vast majority will be located in the primary motor cortex, and these are the ones that we're going to focus on in this class. Similar to our primary somatosensory cortex, the primary motor cortex is situated on two continuous gyri. The precentral gyrus on the superior lateral aspect of the cerebral hemisphere, and the anterior paracentral gyrus on the medial aspect of the hemisphere. The somas for neurons that will be going to activate lower motor neurons to muscles of the trunk and upper extremity are located on the precentral gyrus. Those that are going to activate lower motor neurons to muscles of the lower extremity will be located on the anterior paracentral gyrus. Both of these gyri are located in the frontal lobe. The axons of the neurons for the lateral corticospinal tract travel from the cerebrum through the brainstem with the neurons of the anterior corticospinal tract. Together, this is known as the corticospinal tract until we get down to the caudal medulla. So when labeling diagrams, if you're in the cerebrum or the medulla, you should be labeling it the corticospinal tract. It is neither anterior or lateral until we get into the spinal cord. Once at the caudal medulla, the two sets of neurons are going to separate from each other and run in separate spinal cord tracts. And it's at this point that we have a true lateral corticospinal tract and an anterior corticospinal tract. And now a couple of fun facts that you won't be tested on, but you might find interesting. There are approximately 1 million corticospinal neurons in each cerebral hemisphere. Of these 1 million, about 850,000 are in the lateral corticospinal tract, showing just how much larger it is than the anterior. Of the 850,000 corticospinal neurons in the lateral corticospinal tract, about 80% of them are going to influence the lower motor neurons of the brachial and lumbosacral plexuses. The remaining 20% will go to lower motor neurons of the trunk. Of those 80%, 55% or so, give or take, are going to terminate at spinal cord segments C5 to T1, the origin of the ventral rami for our brachial plexus, with approximately 25%, give or take, terminating at L2 to S2. The axons of the neurons in the corticospinal tract pass lateral to the thalamus and continue down through the brainstem along its ventral aspect. Keep in mind that within the corticospinal tract we have both neurons that will be in the lateral corticospinal tract as well as those in the anterior corticospinal tract. These neurons are going to continue to travel together all the way down to the base of the medulla. On the anterior aspect of the medulla, on either side of the anterior median fissure, the corticospinal tracts form the medullary pyramids. The easiest thing to remember when it comes to corticospinal tract is that throughout the majority of the brainstem, the corticospinal tracts are front and center. Once we get to the bottom of the medulla, where the medulla and the spinal cord come together, an area known as the spino-medullary junction, the lateral corticospinal tract neurons are going to separate from the anterior corticospinal tract neurons. While those anterior corticospinal tract neurons are going to continue down into the spinal cord ipsilaterally, the lateral corticospinal tract neurons are going to cross. They're going to cross in what is known as the pyramidal decussations. Decussation is a crossing, and in essence, it's the neurons of the pyramids that are doing the crossing. So our lateral corticospinal tract crosses in the pyramidal decussations at the spinomedullary junction, then runs down the spinal cord in the lateral corticospinal tract to whatever spinal segmental level is required. Once at the appropriate spinal cord segment, the axon will leave the lateral corticospinal tract and enter the gray matter, where it will synapse with either an interneuron or a lower motor neuron in the ventral horn of the spinal cord. The lower motor neuron will then go on to innervate voluntary skeletal muscle. Lateral corticospinal tract neurons are the only upper motor neurons that have direct synapses on lower motor neurons. All of the other tracts that we have discussed work through interneurons. Here we have a ventral view of the brainstem and some of the inferior aspect of the cerebrum. I'm going to bring up a pointer and show you some of the anatomical structures that we can identify in this view. Starting at the top of the brainstem, which is right here, this would be our midbrain. And on either side, kind of looking like it's a diagonal structure, we have the cerebral peduncle. So we have one on the left, and over here we have one again on the right. The descending motor tracts travel through the cerebral peduncle on their way down into the brainstem and down to the spinal cord. As they continue down this most ventral aspect of the midbrain into the pons, they stay in a ventral position. They move a bit more medially as they enter the pons. They continue down in a ventral medial position in the pons to the medulla. When they get into the medulla, they form the medullary pyramids. So we have a pyramid on either side of the anterior median fissure, this groove down the center right here. Now the most inferior aspect of the medulla has been cut off in this particular picture. But where the medulla ends and the spinal cord begins, at the spinomedullary junction, or where the two come together, this is where the lateral cortical spinal tract neurons would separate from the anterior cortical spinal tract neurons and cross over in the pyramidal decussations to the contralateral side. Once they cross over, they descend down through the spinal cord in the lateral cortical spinal tract in order to get to the appropriate spinal cord. Now let's go ahead and draw in the complete lateral cortical spinal pathway. Here I have drawn a complete lateral cortical spinal pathway. I'm going to pull up my pointer so we can run through it from start to finish. We're going to originate with our soma in the primary motor cortex of the frontal lobe. Because I have selected a lower extremity muscle, the rectus femoris, the soma is going to be located in the anterior paracentral gyrus on the medial aspect of the frontal lobe. So it's going to be extending down into the longitudinal fissure. Had I selected an upper extremity muscle, I would have had to have my soma positioned laterally over here in the precentral gyrus. But since I am doing a lower extremity muscle, we are going to be here on the anterior paracentral gyrus medially. The axon is going to descend down through the cerebrum, traveling in the corticospinal tract. It will pass lateral to the thalamus and then enter the brainstem ventrally. In the midbrain, it travels in what's known as the cerebral peduncle. It continues anterior and medial through the pons and remains anterior and medial in the medulla, along with the anterior corticospinal tracts forming the medullary pyramid. At the base of the medulla, the neurons of the lateral corticospinal tract cross in the pyramidal decussation. They not only cross to the other side, but they angle posteriorly, so that as the upper motor neuron descends in the spinal cord in the lateral corticospinal tract, it is now positioned posteriorly and laterally. Once it gets to the spinal cord segment it needs, it leaves the lateral corticospinal tract, enters the ventral horn where it synapses on a lower motor neuron. Because I know that rectus femoris has root levels of lumbar 2, 3, and 4, I selected lumbar 3 as my spinal cord segment. After synapsing, the axon of our lower motor neuron, which is an alpha motor neuron, is going to travel in the femoral nerve and is going to go to the rectus femoris to innervate it. Here I'm giving you a couple of links that you might find helpful. The first one is a video that actually shows progressive prosections starting at the midbrain and going down, and it traces the pyramidal tracts through the midbrain, through the rest of the brain stem, and down into the spinal cord. It does not show us the start of the tracts, so it doesn't show the cerebrum, but it gives us the brain stem on down. The second one is a schematic of the pyramidal tract as it's passing through the brain stem. So you might find, hopefully you'll find, one or both of these to be helpful in your understanding of our pyramidal tracts. And now a bit more about the primary motor cortex. Like the primary somatosensory cortex, the primary motor cortex has a motor homunculus. It is very similar to the sensory homunculus. Do not worry about the fact that one is prone and one is supine, or that one has a flexed knee and one has an extended knee. For all practical purposes, they are similar enough. We don't have to worry about those slight differences. The primary motor cortex sits just anterior to the central sulcus on the precentral gyrus for representation of the trunk, upper extremity, and face, and on the anterior paracentral gyrus for the lower extremity. Just like the primary somatosensory cortex, there is somatotopic organization. Injuries to the lateral cortical spinal tract present with either paresis or paralysis. Paralysis is a complete loss of the ability to contract a muscle or a muscle group for purposeful voluntary movement. This can be any interruption of the pathway between the primary motor cortex and the muscle, and we discussed this with lower motor neuron injuries previously. Paresis is partial loss of this voluntary control. Common characteristics of lower motor neuron lesions include paralysis or paresis, the extent of which is dependent upon the number of lower motor neurons involved, hypotonia due to fewer weak actin-myosin bonds, and the loss of the ability to contract motor units, hyporeflexia due to disruption of the reflex arc, rapid onset of pronounced atrophy due to a combination of both disuse atrophy, as the motor units are unable to contract without innervation, combined with the loss of the minute amounts of acetylcholine released at rest, and the myotrophic properties of that acetylcholine and the resultant end plate potentials. And fasciculations. Fasciculations are quick twitches of motor units that can, in superficial muscles, be readily seen under the skin. You may have even experienced fasciculations in yourself, as they can occur under healthy conditions. An eye twitch is a common fasciculation. In some ways, upper motor neuron injuries are similar in presentation to lower motor neuron injuries, but in other ways they are quite different. Both types of injuries would be expected to present with paresis or paralysis, depending upon the extent of the injury. However, while lower motor neuron injuries are associated with hypotonia, upper motor neuron injuries are associated with hypertonia, either spasticity or rigidity. Upper motor neuron injuries may also present with hyperreflexia, especially if the injury is in the caudal part of the brainstem or within the spinal cord. Another difference is atrophy. With lower motor neuron injuries, we expect a rapid and pronounced atrophy. However, with upper motor neuron injuries, this is not the case. Especially initially, there is little atrophy because the muscle is still contracting through reflex activation, and there is still those small, tiny amounts of ACH being released at the neuromuscular junction in order to maintain the health of the proteins within the muscle. So atrophy instead has a rather slow onset and a slow rate of progression, as compared to the rapid and pronounced atrophy seen with lower motor neuron injuries. Lesions of corticospinal neurons appear to have more of a pronounced effect on voluntary movement, inducing paresis or paralysis, and less impact on tone and reflexes, while lesions of non-corticospinal upper motor neurons have more of an effect on tone and reflexes and less of an effect on voluntary movement. Due to their close proximity in the brainstem and the spinal cord, injuries to these areas will most often affect both corticospinal and non-corticospinal tracts. As a result, we expect to see interference with the ability to generate voluntary movement, as well as altered tone and reflexes. In this brainstorm, I want you to use your knowledge of upper and lower motor neuron injuries to help come up with a list of signs and symptoms that you might expect for an individual who is experiencing polio. Polio is a virus, and this virus kills predominantly lower motor neuron somas in the ventral horn of the spinal cord and in the brainstem. For whatever reason, the virus typically spares sensory neurons. Knowing that our lower motor neuron somas will be damaged, what types of signs and symptoms would you expect to see in your patient? Here is the full reference that was seen earlier in the discussion on the lateral activation system.